I have one that I think might be like a refer.
Thank you. Okay, so page. Starting at the top, what vessels are we looking at there?
Those would be small.
Yeah, so little capillaries, and what lives there?
That maybe some lymphocytes or neutrophils.
Yeah, I mean, in terms of what conditions live there in this chapter.
Okay, so small vessel vasculitides would be like HSP, mixed cryoglobulin.
So excellent. So HSP, mixed cryo, most drug-induced, most connective tissue-induced vasculitis, serum sickness tend to live there at post-capillary venial, which is, I think, what you thought I was pointing at. So, which is right where the reticular dermis meets papillary dermis. So that's post-capillary venial. Up a little higher in the papillary dermis are the capillaries, and that would be pigmenting purpuras, mainly, that live there. And then down here where you have arteriolar type vessels, what lives down there?
DAN, Wagner's, Strauss, and medium and large vessel.
Exactly. And septic and rheumatoid vasculitis. Differences between the two also include the purely small vessel vasculitides tend not to necrose endothelium. The larger vessel vasculitides, even when you have a superficial biopsy, they differ in that they tend to necrose the endothelium. In this case, we have hypertrophy of a vessel, abnormality of a vessel. Don't really see inflammation of a vessel, but there's something funky with that artery. I see just a few neutrophils here on higher power. So when you have a thrombus, some newts in that large arterial vessel, what's your differential?
Wagner's.
Yeah, so
Big Five, I guess.
It absolutely could be anything in the Big Five. This patient turned out to have polyarteritis nodosa. The other one to throw in, if you have arteries and veins and the inflammation, here there is a little bit in the wall that you can see. But if it's entirely in the clot, that's what you see in burgers. Young Indian male, classically young Indian male, sitting with his stump on the side of the bed, chain smoking, would be like the classic picture of burgers. Much more common in South Asia. Heavy smokers, addicted to their smoking despite the amputations, is kind of the classic for burgers. And there, it's less the vessel and more the thrombus that's inflamed in burgers. Okay, that's sort of a walk through all of vasculitis in one slide. Okay. So, Nicole, before we start, give me one drug that instead of producing post-capillary venial vasculitis tends to produce deep Churg-Strauss type vasculitis. You want to jump in? Yeah, leukotriene inhibitor, montelukast.
Okay.
And montelukast is used to treat asthma. Churg-Strauss presents with asthma. It all gets very complicated. So, but montelukast is the one drug implicated in causing a big five type of vasculitis, classically. So, very good. And the one connective tissue disease that tends to do larger vessel vasculitis is rheumatoid vasculitis, correct? And the difference is, you look at almost any connective tissue disease vasculitis, it's purpura on the legs. You look at rheumatoid vasculitis, it ulcerates because it knocks out those arterioles. Okay, So, Shane, what do you see here?
Superficial ND.
Superficial and
Well, it's kind
maybe superficial and mid, and
Okay.
mid is perforators. That's no man's land.
Okay.
So it doesn't help you big 5, little 5. Those are just perforating vessels, either one.
Definitely some neutrophils and some kerorexis.
Neutrophils, kerorexis, expansion of the vessel wall, fibrin, imagine that in this chapter.
What are the odds?
Okay. What are the odds of that? Exactly. Eosinophils present. They don't really help you Churg-Strauss versus non-Churg-Strauss, drug versus non-drug. They can be there in any LCV. You know, if it's a purely eosinophilic vasculitis, that's probably Churg-Strauss. Anything short of that, the EOs just don't help you. Okay, how about your endothelium? Gone or still there?
I don't see any nucleus.
Do you see
I
a
guess
nucleus
what-
right there at
what
the
you're
tip of the
pointing
arrow?
at,
Yep. So, you know, they're still there. Everywhere you look, the nuclei are still there. So, endothelium intact, postcapillary venial, neutrophils, kerorexis, expansion of the vessel wall, fibrin deposition. What do we have?
What's the small vessel or the little 5?
Yeah.
Not sure.
And the little 5 again are?
We have HSP, serum sickness, connective tissue disease, mixed anemia, and drug.
Drug. Very good. Excellent. Nicole, name one drug that paradoxically produces a larger vessel vasculitis, larger people. Montelukast. Very good. So early on, they thought that patients were on prednisone, they were steroid dependent for their asthma, and then you could put on Montelukast, you could take away the steroid, and you were just unmasking Churg-Strauss that was already there. But there are plenty of patients now who've been on Montelukast for some other indication. It wasn't asthma to begin with, and it caused Churg-Strauss, so it's real. Okay. Okay. Jessica, what do you see?
So it looks like we're most likely sort of on the face of the site.
Looks like facial skin
You have sort of nodular lymphoid infiltrates,
around the,
vessels.
yep, imagine that in this chapter. Okay.
Looks like there's some edema as well.
And is it a top to bottom, side to side process, or does it very boxy and compartmentalized?
It seems very boxy and compartmentalized.
And in fact, it leaves a little border zone between the inflammation. So if you were a German pathologist and you were trying to say there was a border zone there, what would you say? A Grenzzone. Grenz just means border, right, in German. So there's a little border zone or a little uninvolved border between it and everything around. And in fact, that uninvolved border means it makes little boxes, little squares, little, polygons of some sort separated from one another. And then if we saw neutrophils, kerorexis, and EOs at higher power, what would you think?
I would think about granuloma faciale.
Where is the granuloma in granuloma faciale?
Nowhere.
Well, or in the name, right? In the name, not in the tissue, right? Where are the eosinophils in eosinophilic fasciitis?
Peripherally.
In the blood. Yep. Again, not in the tissue, reliably. So lots of misnomers. No mycosis in mycosis fungoides. No granuloma in granuloma faciale. There are EOs in eosinophilic fasciitis, but they're on the peripheral smear, right? So things that might otherwise mislead you in terms of what to expect.
That looks like a paintball.
I mean, it looks like we could have a little EAC on our hands here.
So, could be EAC, absolutely. EAC, you tend to have a focal spongiotic
Don't really
process, parakeratosis, but gyrate erythema absolutely in the differential because you're seeing a perivascular lymphoid infiltrate that's pretty tight, right? So that can be a figurate or gyrate erythema. Superficial scaly gyrate erythema is EAC, and then you've got lots of other gyrate erythemas, some of which are perineoplastic. What is the most reproducibly perineoplastic gyrate erythema?
Erythema gyratum repens de la Mancha.
Thank you, very good. And what does EGR look like clinically?
Oh, it's described as wood grainoid.
So, and it really does look like wood grain. So you'd see this picture of this scaly rash that's wood grain. That is almost 100% perineoplastic. And it differs from tinea concentricum, which is also wood grain. How? By the positive KOH would be one,
Yeah, that's
right? But
negative PET.
But how about clinically?
I would imagine that to do with the scale.
You might imagine that, but you would be wrong. So erythema. So in EGR, it's always on a base of erythema. In T concentricum, the whole pathology is that those people are immune tolerant of the tinea, so they mount no immune response at all, so there's no erythema.
Oh.
Okay, back to this slide. So if you were to roughly draw a shape around this, what kind of shape would you say?
I would call it a wedge.
A wedge, since it has, at its base there. We use that shape for all kinds of things. In inflammatory, it tells you that it's superficial and deep based on a central deep vessel. In melanocytic, broader at the top, like a triangle with the point at the bottom is usually benign, whereas the reverse of that is usually malignant in melanocytic. In lymphoid, the same thing. Lymphoid and T cell tend to be a triangle with the base point at the bottom. B cell tends to be a triangle with the point at the top. Okay, so just when you look at those, those are some of the patterns that we look at in pathology. Let's look a little more here. Tell me about the lumens here.
Hard to find.
Hard to find. So when you have lots of perivascular infiltrate and yet the vascular that it's peri to is hard to find, what does that mean about the endothelium?
It's not
pretty swollen, right? Okay, so lack of lumen equals lack of lumen equals endothelial swelling. So you have a wedge-shaped infiltrate. I see eosinophils. I see very prominent endothelial swelling. What are we probably dealing with?
Potentially an arthropod assault.
Arthropod assault. You can say bug bite if you want. We all know they sometimes sting instead of biting, but arthropod assault, bug bite, whatever. So wedge-shaped. Polymorphous, meaning there's some EOs present. And you really don't see... I can make out one lumen there with blood. Nowhere else can I make out any lumen with blood. So that's kind of the scan of a bug bite.
Okay, so there are these very dense lymphoid aggregates again. There is a little bit of a Gren zone. There's going to be vasculitis within here, I'm sure. You're pointing out some neutrophils.
Yep.
It looks like EED.
So you have vasculitis, lots of newts, few EOs, definite Gren zone. If this were facial skin,
You'd call it granulofacial.
if it were extensor skin.
EED.
Yeah, they're pretty much the same. Difference is EED, just because of where it is, you tend to get more onion skinning of vessels over time. Facial skin just isn't prone to that. Granuloma faciale, you tend to get more hemosiderosis over time. EED, you get more cholesterol building up over time from all those erythrocyte membranes that are left behind. But otherwise, they're sort of variants of the same process. But when you look at them, which one is associated with paraproteinemia and which one usually has no systemic association?
Granuloma faciale usually has no systemic association, and EED you need to work up.
Yep. And EED, there are workups that can be streptococcal induced or it can be paraprotein induced as the two most common. So, two probably variants of the same condition, but the location is predictive of the associations. Dr. David Perry.
Let's see. So we have a little punch biopsy. Kind of sparse infiltrate. It's a little bit interstitial as well.
So it's a sparse infiltrate, superficial and interstitial. When we look at that infiltrate,
it's lymphoid predominantly, some EOs.
And I see a fair number.
Neutrophils.
Fair number of EOs. I see some newts. When we look at the vessels, there are definitely some newts in the lumen.
So you have like a urticarial process. It doesn't look like there's vasculitis per se.
Yeah. So the main difference at scan between early vasculitis and urticaria, both are neutrophilic processes. In leukocytoclastic vasculitis, you have, shockingly, leukocytoclasia. Right? So if you have no karyarexis, it is not vasculitis. Whereas in urticaria, it's very rare to see any karyarexis. So, very common in urticaria, the EOs start to appear, but that's over time. So initially, it is neutrophils only. So vessels stuffed with neutrophils. That's acute urticaria. Vascular lumen packed with neutrophils. No karyarexis. Then they start working their way out from the vessels. Still no karyarexis. Then the EOs appear. Still no karyarexis. So that's the life of an urticarial lesion. Name some other neutrophil-mediated dermatoses that can look sort of like vasculitis but aren't vasculitis.
Sweets.
So sweets would be a classic one. What does sweets look like on scan?
It's more dense, like diffuse infiltrate.
So nodular and diffuse infiltrate of neutrophils, karyarexis. You can have some vasculitis. So in sweets, you have a lot of karyarexis, right? Tons of karyarexis, just like in vasculitis. And you can have some actual vasculitis in sweets. So how do you know at scan that it's not vasculitis?
With papillary edema.
Papillodermal edema. Big papillodermal edema. Prominent papillodermal edema. Okay. So papillodermal edema with lymphs, think polymorphous light or perniosis. Papillodermal edema with newts, think sweets. So papillodermal edema lymphs, what do you think? PMLE or pernio. And papillodermal edema with newts, think sweets. So it looks just like sweets, but it's not sweets. What else can look just like sweets?
GM-CSF.
So you might have gotten granulocyte stimulating stem cell stimulating factor or GM CSF. So either one can produce a sweets-like reaction, or what else?
Like bowel bypass.
Bowel bypass. So blind loop bowel syndrome looks exactly like sweets. So that's kind of your differential. Very good. And that's important in, for instance, you could imagine a testing evaluation situation where you have a slide that looks just like sweets, and yet sweets is not on your pick list.
Writing candidate.
But something that could look just like sweets could be the one that's on your pick list, right?
So in our mnemonic we have like GCSF just causing sweets. Are they actually two different things? Or
Well, it's sweets-like.
Okay.
Yeah, because when you're, sweet syndrome is recurrent on its own, right?
Okay.
So every time you get a URI, you have peripheral neutrophilia, and you have these hot red plaques.
Okay.
That's sweets. That's what Dr. Sweet described. Then there's things that are kind of like sweets. So you have the paraneoplastic, ones with leukemia. They look different. They're dusky, they're purple, they're necrotic. They look half sweets, half pyoderma gangrenosum. And then you have bowel bypass, which you have a cause and it's not a recurrent URI. So it's not a young woman with this each time she gets a URI. And then you have GCSF, and that's drug-induced look-alike that goes away when you withdraw the agent. So, okay, well done. Let's do.
Alright, so it looks like they have pretty extensive, almost like an ulceration there, maybe?
Yeah, so you got an ulcer, and then what's all this intensely staining stuff in the dermis?
Fibrin.
Fibrin. So we got an ulcer and we got fibrin. All sorts of things could cause an ulcer and fibrin. Would a little 5 vasculitis ever cause an ulcer?
Most likely not.
Yeah, kind of hard to imagine. Could a big 5 vasculitis
Sure.
cause an ulcer? Sure. Could trauma cause an ulcer? Could infection cause an ulcer? So if you're in the vasculitic world, more likely big 5, but there are lots of other things that cause ulcers too. And here we're just seeing an ulcer, so there's nothing specific or diagnostic about that. Be careful, because you're always going to get a little vasculitis in any ulcer bed. Traumatic ulcer, regardless of what the ulcer is, decubitus ulcer, you're going to have a little bit of vasculitis in the ulcer bed. So, that just goes with having an ulcer. So now you go away from the ulcer to see what the cause might be.
Looks like I have some hemosiderin deposition.
A lot of hemosiderin deposition. And tell me about the vessels. Are they solitary or are they in cannonballs?
Cannonball.
So you have cannonball angioplasia and hemosiderosis adjacent to an ulcer.
So you think of like peachy? No. Sweet. Oh, yeah, stasis dermatitis.
Stasis! So you're describing all of these changes of stasis, which is the cannonball angioplasia and hemosiderosis. So you have changes of stasis, and next to that an ulcer. It could be an infectious ulcer in someone with stasis, or it could simply be a stasis ulcer.
Yeah, I was thinking of lipidoid or whatever, vasculopathy.
So lipidoid vasculopathy
that'd be
looks a
different.
little different in that the lumens are tiny, tiny little lumens, always containing thrombi with hyalinization of the vessel. In this case, you have nodular angioplasia, but I don't see thrombi, and the vessel wall is not hyalinized.
Okay.
So that's stasis rather than atrophy blanche. Atrophy blanche, nodular angioplasia, but the vessel has almost no lumen, and what lumen there is, there's a thrombus sitting there. Okay. So, Blake, what do you think?
Looks like very sparse dermal infiltrate.
Yeah, pretty sparse dermal infiltrate.
See some nudes.
Sorry. get ourselves back to where we want to be. Sorry about that. That's a good field. How about right there?
So some EOs, looks like they're in the vessel.
So a vessel packed with neutrophils, and I see plenty of neutrophils around that vessel. Do you see any leukocytoclasis? Any?
I do not.
So no karyarexis, no nuclear dust, no leukocytoclasis. That's all the same thing. Those are synonyms, right?
Yep.
So
Urticaria.
So looks like urticaria, right? Early urticaria, just newts packing the vessel. Later urticaria, the newts make their way out, but there's no karyarexis. Even later, EOs join, but still no karyarexis, right? We did once get a ward consult, and the patient had been moved to radiology and was in where they could find a lead-lined room, because the biopsy report had said there was nuclear dust in the biopsy.
No way.
Honest to goodness,
my
yes.
God.
It's not.
That was some intern being like, holy cow.
Exactly.
Midnight.
That was during the Cold War, though.
Different, which is one of the reasons why we don't say nuclear dust. We say karyarexis, right?
So
There's broken nuts everywhere.
is the edema? You don't see it in urticaria. Is that like
Oh,
because of the fixing
so-
process, or
So sweets has enough edema that you see it histologically. In urticaria, occasionally you see a little infectasia, not usually. There's not enough in a wheel to have histologically evident edema.
okay.
Occasionally a little infectasia. Whereas sweets, it's massive papillary dermal edema. PMLE, massive papillary dermal edema. Perniosis, massive papillary dermal edema. You see that in other things too. So, for instance, in myxedema, so thyroid myxedema, or hypothyroid myxedema, you're never really going to see the mucin. There's not enough.
Okay.
Whereas in pretibial myxedema, you'll see the mucin. So the amounts of things help in differential. Yes, ma'am.
And it just be me, when I see a slide that's faded, it's often really hard for me to tell like if there's dermal edema or if it's just like faded. Is there like a trick you have for knowing if there's
Look for lymphectasia.
Okay.
If there's edema, you'll have dilated lymphatics.
Okay.
For instance, this one at scan, you see these thin-walled, irregular vessels there, right?
Okay.
There's no papillary dermal edema. It's not a sweets pattern, but this was a little indurated, a little edematous, just enough to give you lymphectasia. And you can tell the difference in the vessels because it's a thinner wall and they tend to be a little irregular, just slightly staghorny. Like all of these things are lymphectasia.
Okay.
The other thing that helps is you have a perivascular infiltrate here that's around the postcapillary venule. There's really no infiltrate around those lymph vessels, right? They're on the side, so they're not the heme vasculature, they're the lymph vasculature. Okay? So, Brian, so we know this thing was a little bit edematous, right? A little bit indurated.
Yeah, my first thought was, given like the sebaceous glands, I was thinking we might be on face and looking at like granuloma faciale picture.
That
Some
would
of
not
them-
be a bad thought.
Yeah, it seems to have that nodular look, lots of EOs, some neutrophils in there.
But I don't see the granuloma.
So we won't find it.
Yes, you won't find it because, other than in the name, you're not going to find granuloma and granuloma faciale. It's chronic perivascular facial leukocytoclastic vasculitis, but don't forget it's really common on chest and back too. And on chest and back, you're going to see something that's kind of reddish brown. You're going to think Bowen's, but in retrospect, it looked just like GF. It was just that it was chest and back.
That's true.
Doing a pass or play?
I can attempt.
You can attempt, that's fine.
Um,
And remind me of your name again, I'm sorry.
Jenny. I go by Jenny.
Jenny?
Mhm.
Okay, so go ahead.
This looks like a true vasculitis.
Looks like a true vasculitis. You definitely have neutrophils around a vessel wall. Do you see any karyarexis, or are all the neutrophils intact?
It looks like there's some karyarexis.
So if you can make out that the fragments are kind of connected to one another or grouped, then it's an intact neutrophil.
Okay.
Right? So the best way to, at scan, the best analogy I've heard is it's ants at a picnic.
Okay.
If all of the ants are intact, you're fine. If there has been ant carnage and you have ant heads rolling about, dismembered ant heads, then that's karyarexis. Here, they look like ants. You can make out segmented bodies that are all grouped together.
Okay.
So given that we have no karyarexis and we have EOs,
so a dense perivascular neutrophil infiltrate, something like an urticarial.
yeah, so it looks like an urticarial response. So Brian, jump in. How would stills look different from urticaria?
I feel like you might have more of a karyarectic look.
No. Stills doesn't get karyarexis either, but it also doesn't get the EOs. So stills looks just like urticaria, except it stays neutrophilic. The EOs don't show up. So in stills, the EOs weren't invited to the party. It's really sad. They never got an invitation. They feel left out. But Still's disease looks just like urticaria, except that the EOs never join in. Right.
I sometimes get those weird little IP-looking diskeratotic cells.
Not
Thank you. That was the next question. So you brilliantly pointed out. So what we just described was the acute urticarial rash of Still's. But Still's patients also get a more persistent, often papular rash. And so, the neutrophilic without karyarexis, that's one look for Still's. Another characteristic look for Still's is a ferritin of 2,000. Right? That you have a patient with a ferritin of 2,000, you're probably dealing with Still's, right? The other thing is these funny, you're thinking viral exanthem, but it's really persistent. And when you biopsy, it looks almost like incontinentia pigmenti with dyskeratotic cells everywhere. That's also Still's. And then what does it look like as that matures? Whorls in the corneum, right? So that's the last look of Still's is you've missed that exanthem-like rash, but what the patient has just sort of brown hyperkeratosis that's patchy. And when you biopsy, it looks like the Van Gogh's Starry, Starry Night up in the corneum, right? That there are these corneal whorls up in the stratum corneum. And that's late-stage Still's. So early Still's, neutrophilic with no karyarexis, just like urticaria, but the EOs are never invited to join the party. Later exanthem-like Still's, you may have that sky-high ferritin. You have dyskeratotic, lots of individual dyskeratotic cells in the epidermis, like incontinentia pigmenti. And then late Still's, starry, starry sky pattern in the corneum where you have whorls in what should otherwise be a basket-weaved corneum. Okay. Very good. How are we doing time-wise? We're doing okay. Okay, Dr. Dunn.
It was superficial dermal infiltrate.
And what else do you have here?
There's some is that perikeratosis or like a crust?
It's a crust.
Yeah.
So difference between perikeratosis and a crust is perikeratosis contains neutrophils and often serum. Right? So the pink stuff is the serum.
Right.
The little ants at the picnic are the neutrophils. And then there's some para there too. Right? So that's a crust. So this was clinically a crusted lesion. And then what do you see?
A lot of eosinophils.
Eos, newts, a little cardiorexis, not much, but there's vascular damage, right? See all the red cell extravasation? So you have vascular damage out of proportion to the number of neutrophils. Vastly out of proportion to the number of neutrophils. So you got a crust, vascular damage out of proportion to the neutrophils. And tell me about your blood vessel lumens.
I see cells there, so I think there are edematous there.
Yeah, so you have endothelial swelling. Some areas where you have newts in the vessel, but does urticaria crust?
No.
No.
Maybe
Does Stills crust? I mean, none of those things crust, right? So you know it's not any of those things. So it's something else that has newts plugging a vessel but crusts, and it has prominent endothelial swelling and a fair number of eos and some vascular damage. Bug bite. Yep, exactly right. And then tick bites in particular look different in that in the acute stage of a tick bite, you lack the eos, it's all neutrophilic, and you have a lot of fibrin that's leaked out of those vessels. So thrombi, fibrin leakage out of vessels, neutrophilic without the eos, that would be a tick bite early on. And that all that blue, it's actually, I misspoke, it's not even fibrin, it's fibrinogen. Because fibrin is red, fibrinogen is blue. Right, so it hasn't even had time to polymerize, it's just leaked out. Okay, Katie.
So, a really compact corneum with some perikeratosis. You have superficial and deep infiltrate.
So,
Perivascular and perinexal.
so tell me about the time course of the lesion.
There's acute on top of subacute horn, so probably like a week or 2 weeks old.
Yeah, so this lesion is a week or two old because you still have your retained normal basket weave corneum, and under that you have a subacute horn that's perikeratotic and more compact. Okay, and then what is happening in the dermis of this week or two old lesion?
It looks like superficial and deep perivascular and perinexal infiltrate.
Okay.
I'm just going to make out lamps. On the deeper vessel, it looks like there's some fibrin. Yeah, fibrin plugging more probably medium-sized vessel like you
Yeah,
see.
so first off, it's very, very round, like an arterial, right? And what you can make out of the muscularis is like a wreath. So that's all features of a little arteriole. And it is thrombosed, and there is some inflammation, and you rightly said just in the kind of pattern you see with PAN or with microscopic polyangiitis. All right, so this, puts you into a big five, probably ANCA-associated vasculitis, probably PAN or microscopic polyangiitis. So what organ do you want to look to?
Check their kidney.
Kidneys, yeah. So a lot of these, it just points you. Are you looking at their heart? Are you looking at their kidneys? Are you looking at their upper airway? That's the pattern will help you.
It looks like acral skin. There's some serum crust there.
There's
some serum.
definitely some crusting here.
And looks like superficial and deep perivascular infiltrate mixed with lymphocytes and some eosinophils.
And what are these bright red?
Looks like thrombi in the vessels.
When I look at it, it's not really a lumen. I can make out like striated collagen there, but it's all red.
So more like Wells syndrome?
Yeah, like flame figures of Wells. So let's go back to scan. So those are flame figures like in Wells syndrome. And what is Wells? What causes Wells?
Kind of mass activation of the eosinophils.
Yeah, and 99% of them are probably fancy bug bites. Right. So Wells is, most of them is bug bite. When Wells first described it, he said he thought he was describing an exaggerated bug bite, and then the world said, no, this is idiopathic, and named it Wells syndrome, and then the Germans very nicely showed that they could provoke it with bug bites, and published an article. Wells was asked to write an editorial, and his editorial was, I told you so, period. So when you look at it, you can make out the collagen. You can see the linear bits of collagen with that red around it. So that's a flame figure. So definitely has a Wells appearance, except that this person is 22 years old and just suffered an MI and has a P-ANCA and acute renal failure. So put together something that looks kind of like...
Churg-Strauss.
Yeah, exactly. So Churg-Strauss granulomas start looking just like Wells flame figures, but then they form granuloma around those flame figures. So early Churg-Strauss can be just LCV with necrosis of vessels, superficial and deep, can be flame figures that start to form granuloma around them, or can be a true eosinophilic vasculitis. Any of those can be what you see early in Churg-Strauss. And it's important because it beats pretty hard on both kidneys and heart. Okay. Nicole, what do you see?
So, starting from the top, the corneum and the epidermis look fine.
Okay.
There's not really much of an infiltrate in the papillary and reticular dermis.
Yep, agree.
Oh, there's something going on in that.
Yeah, it's one of those, I don't see it, oh, there it is.
That
So
looks
what
like
is it?
clefting, so I would think maybe like a cholesterol amylase or something.
And if you got someone with blue toes on the ward and you really want to find them, you go right in the middle of the blue infarct and you ask them to do frozen section. Because if they polarize, here, this is paraffin embedded, formalin fixed paraffin embedded, routinely processed, all the cholesterol's gone. But if you do frozen section and you do polarized microscopy on your frozen section, it just lights up like a diamond down in that vessel. So it's, just a thing of beauty.
You put it in saline for frozen, or sure?
No, you can put it in formalin.
You can put it in formalin.
It just, you don't want it to go through xylenes and alcohols.
Okay.
It's really the xylene that alcohols dehydrate, xylene removes lipid. So xylene or histoclear remove lipid, alcohol removes water.
If you put it in formalin, though, it likes to slide off the slide when we go to hand stain it. So saline or bring it down dry and fresh.
Better.
Yeah.
Okay.
We can do it, it might take us a lot longer.
Okay. So if you're mad at your friend in PATH, if you if you don't want your car keyed, then you okay. So Kate, what do you see?
So maybe it looks like facial scan or something like that.
Yeah, could definitely be facial skin, and in fact, someone pretty hairy, so maybe more like scalp.
Yes.
Okay.
So I believe in that section, yeah. You have a kind of a deep vessel with some transmural inflammation.
Yep.
And
So large, deep vessel.
I think it may be like temporal arteritis.
So like temporal arteritis. In order for it to be temporal arteritis, here we see mainly neutrophilic.
Mm-hmm.
So in this one, it would be key to get a CD68, because if you have no histiocytes, if you have no giant cells, you do not have giant cell arteritis. Okay, so the histiocytes have to be there. Early on, just like this, you can see necrosis, you can see newts, but the giant cells have to be there to make the diagnosis of giant cell arteritis. They are a must. Otherwise, you could conceivably be dealing with PAN, with an ANCA vasculitis, with something else. This was, it's scalp skin, this was temporal. They were looking for TA. Clinically, the patient had TA, but you would expect at least some histiocytes in there, and over time, real giant cell. But early on, you can get some neutrophilic infiltrate in it. Important because the vessels, all the manipulation and injection and everything recruits polys. So it's really common on PAN specimens to see neutrophils in there. If there are no giant cells, it is not giant cell arteritis.
Okay. Let's see what we got here.
So it looks like you have a little bit of papillary dermal edema, but hormones pretty acute.
So papillodermal edema, acute horn,
Maybe some neutrophils there.
maybe some neutrophils. So if you have neutrophils, now there is a suppurative folliculitis there, so it brings up the possibility of tinea and all kinds of other things. But if that suppurative folliculitis is a red herring, and I have nodular and diffuse neutrophils, and I have pretty marked papillary dermal edema, what pattern am I in? Like a neutrophilic dermatosis, very cleverly said. So you didn't get suckered into saying sweets. So what are your neutrophilic dermatoses?
So sweets, if they have like the Michael Wells or Mediterranean fever.
So a lot of the autoinflammatory, in fact, almost all your autoinflammatory syndromes can produce sweets-like lesions.
You have PG or bowel bypass.
And neutrophilic dermatosis of the dorsal hands, all of those.
I'm seeing a lot of papillary dermal edema again, it looks like.
So is it papillodermal edema or is it epidermal necrosis?
Oh, it looks like epidermal necrosis.
So it's epidermal necrosis, but not papillodermal edema. And that, makes it more likely that it'll be a bug bite, a tinea, something other than true vasculitis when you have the epithelial change.
Mm-hmm.
But sometimes it's just that the vasculitis was bad enough that it necrosed the epidermis. So, you've got that differential to keep in your mind.
Mm-hmm.
And then when you look at the vessels,
so it looks like there's a lot of caryorexis, sorry.
yeah, so we have ant heads. We have decapitated ants, right?
They look intact, so it looks like it's more LCV.
So there's fibrin. You can make out that red fibrin in the vessel wall. Acute tick bite, fibrinogen that's blue, fibrin is red, so you've got red fibrin, expanded vessel wall, lots of ant heads, so caryorexis, EOs.
Good for a bite.
Tell me about your endothelium.
It looks intact and
Intact.
swollen.
So, absolutely could be bug bite, especially with that epidermal necrosis. That would probably be my top, would be arthropod bite. This one actually is a biopsy from someone with HSP who had some epidermal necrosis just because it was a long-standing, pretty bad vasculitis. But histologically, bug bite would be higher for me because of the epithelial change. So I would have gone exactly where you did. Jimbo.
Looks like we have, again, edema, like pallor of the papillary dermis. There's interstitial and periadnexal. Looks like a lot of eos and neutrophils and big time nuclear dust and crap around there. And there's a chunk of, in the epidermis, it's like a
Serum death. Yeah. I mean, crud. Okay. So it's a cruddy epidermis, and you've got vasculitis, and you've got lots and lots of eos, as you said, and it's superficial and deep. And do you see much of a lumen?
Not much lumen to speak of.
So you're thinking
Bug bite.
Bug bite. And if you look at these are early flame figures. So this is like bug bite that's wanting to turn into wells.
Mm-hmm.
And you know they're flame figures because you can see those eosinophil granules adherent to the collagen. Right? So those are early flame figures. But wells is just a fancy name. Right?
Love to hit that with a major basic protein stain.
I would assume that would be a good thing to do, and it would be positive.
Mark on this splotch.
Okay.
There's the treatment too.
Okay.
So, very thin shade.
Very thin shade.
And there's a very sparse infiltrate.
Very sparse infiltrate. And what's it composed of?
Mostly lymphocytes.
Yeah. They're not segmented bodies like ants. They're round. So it's lymphs.
And there's a little red cell extravasation around there too.
Yeah, so there's red cell extravasation in lymphs. Now, what vessel is that?
Post-capillary venal.
So if that's the post-capillary venal, then what's bleeding?
We're up in like the capillary area.
So it's the capillaries that are bleeding. So a lymphocytic capillaritis with bleeding. And I expect blood to look red. Why is it kind of brown mixed in with the red?
A little bit of old blood in there, so like methadone.
So what would be a chronic lymphocytic capillaritis that would lead to hemosiderosis and pigmenting purpura?
I think there's a name for it. It's pigmented purpuric dermatosis.
Yeah. So pigmented purpura eruption, pigmented purpuric dermatosis, pigmented or purpura pigmentosa chronica. So PPE, PPD, PPP, progressive pigmented purpura. PPC, pigmentosa purpura chronic or purpura pigmentosa chronica, anything with a lot of PPs in it, and an ESC or anything pretty much refers to Miyake-Schomburg disease. And then Miyake's looks thumbprint-like. I'm sorry, I said that wrong. Schomburg's is thumbprint-like. Miyake's is annular and telangiectatic. Gouger Bloom is lichenoid. It looks kind of like LP that turns brown.
And then Ducus and Capilonacus epidermis.
So Ducus and Capilonacus are spongiotic. So it looks like nummular eczema that turns brown.
Are they that way on path too, or are we just talking clinically?
And on path too.
Okay, they're lichenoid on path.
So Gouger Bloom is lichenoid on path, which is why it looks lichenoid clinically. So it looks like LP that turns brown. Ducus and Capilonacus is spongiotic, so it looks like nummular eczema that turns brown. To help you remember the maybe not politically correct, but Greek sponge divers, so you have the Greek names are spongiotic. So if that helps you. And then there was one group that thought the French were in your face, so interface went with the French names. So there we're getting really politically incorrect, but they weren't mine. but spongiotic and the Greek names. So if you remember your friend who's the Greek sponge diver, that may help.
A sponge charter in Greece.
Okay.
Shave biopsy is acute horn. Dermis looks okay. It looks like there's a little bit of Caryorexis.
So there's definitely Caryorexis here.
Let's see, this looks lymphocytic as well, predominantly.
So they're lymphs, but they're definitely newts and Caryorexis. Tell me about your papillary dermis.
There's also a little bit of epidermal fibrosis.
No, it's not fibrosis, but it's definitely a widened papillary dermis, so there's probably some edema there.
Edema, okay.
So if there's papillodermal edema and nodular and diffuse newts with Caryorexis,
So we're kind of in the sweets.
yeah, then you're kind of in the neutrophilic dermatosis sweets differential. I want to break my slide. Thank you. Okay. Let's see what else we got in here. Okay, Rob.
So it looks like we have some pretty intense fibrin deposition and
So you got fibrin deposition, and a lot of that fibrin is
within vessels.
within vessels. So you have lots of fibrin thrombi, and your vessels are in cannonballs.
Right.
And tell me about the size of the lumen.
So this is livedoid vasculopathy.
This is livedoid vasculopathy.
The
So
other
you've
one-
got cannonballs,
Second time.
but those lumens, I mean, you've got, the lumens, a lot of these are like 1 erythrocyte wide. They're these puny little lumens. So, and what is the rest of the rest of it's amphiphilic? That's vessel wall. So you got that big hyalinized amphiphilic vessel wall, tiny little lumen, nodular angioplasia, and fibrin thrombi. That's livedoid vasculopathy. What if you've got livedoid vasculopathy and you're stroking?
And you're in trouble.
Yes. Any syndrome that goes with that?
Sneddon.
Sneddon, and Sneddon is commonly associated with marker, serologic, antiphospholipid. What if you are 16 years old, have polyarteritis nodosa, and a stroke? So early onset PAN with stroke. In this past month's Chad.
Difference yours is like 2 months behind. We're getting there.
Okay. So that's the adenine deamidase data 2. So adenine deamidase is one of the causes for severe combined immunodeficiency, but there's another adenine deamidase syndrome, which is the data 2, which is early onset PAN with stroke. So these are kids, teenagers, people in their 20s with PAN and stroke with a familial inherited syndrome.
Do we have a Dagos yet?
We have not looked at a Dagos yet.
3 minutes.
So Dagos is rare. Most of those patients turn out to have lupus. But some are idiopathic. They are going to have acute abdomen because of their bowel perforation. They're going to stroke. And histologically, you're going to see a red papule that develops an ivory white atrophic center. Histologically, it's a true lymphoid vasculitis with vascular necrosis. And over time, you get mucin in the dermis, not surprising since most of these people have lupus. There are some in there, but you have to kind of hunt. Yeah. We do have some Dagos. in there. And I think there's Dagos in the chapter, there's some
There's a
pictures,
picture
right?
of Dagos in there.
So, okay. And then we got to get to clinic, so this is our last one.
Looks like a palisading granuloma almost.
Actually, we're going to do two others lightning quick. So you see palisading granuloma with neutrophils in the center, and you are on erectile tissue with glands. That would never be genital erectile tissue because mucin glands there would just be gross. So this would be then nasal mucosa, right? So erectile tissue with glands is nose, snotty nose, right?
So GPA.
So, or palisading granuloma with neutrophils in the center, schnoz would be. You said it correct. You said the politically correct. Yes.
I was trying to be politically.
Yes, because Wegner was a Nazi, and so they don't say Wegners anymore. They say so granulomas with angiitis, angiitis with granulomatosis, and then Churg-Strauss. Neither one of them did anything bad, as far as I know, but their name has gone away too. Okay. Just real quick, just to walk you through. Yeah, we're going to skip that one. Let's go to this one in the interest of time. Okay, so we are on acral skin. We have not so much papillary dermal edema on this one, but you have a perivascular infiltrate, and every lymph sits on a background of white. So when you look at most perivascular lymphoid infiltrates, the lymphs overlap one another, and you see red collagen behind them. Here, every lymph has its own identity and sits on a background of white. You know, like a little black thing on a white background, right? That's the fluffy edema of perniosis. So perniosis you expect to be acral skin. All the limbs have their own identity. They're separated. They're on a background of white. That's fluffy edema. That's perniosis. A third to a half of perniosis patients are presenting for what? Systemic disorder, lupus. Exactly. So they all get ANAs. And that's it. So
Thank you.
Any chapter?
Yeah.